Good evening, everyone. Welcome to our COVID-19 update for primary healthcare providers this evening, hosted by the Adelaide Primary Health Network and facilitated by Dr Melanie Smith, Dr Emily Kirkpatrick, and we have Dr Susie Pedler with us this evening also to provide us with a presentation. I'll just do an acknowledgement to country before we get started. So we acknowledge the Kaurna peoples who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connection to land, waters and community, enduring now as it has been throughout time. We pay respect to them, their culture and to elders past and present. We'd also like to acknowledge and pay our respects to those Aboriginal and Torres Strait Islander people who work from other nations who live, work and travel and contribute on Kaurna country. Māori ngā putni, welcome. I'm going to hand over to Dr Melanie Smith to kick us off this evening. Thanks, Melanie.
Good evening, everyone. Thanks for joining us. Sorry you're left with me this evening. I think Emily has run into some technical difficulties getting on. Hopefully she will make an appearance shortly to give us an update on where things are at with COVID in SA at this stage. We've got the wonderful Dr Susie Pedler joining us this evening, who's going to give us a bit of an update on COVID vaccinations. I know there's been a lot of movement in this area over the last several months, and different groups becoming eligible for different doses and new vaccines on the horizon. So we thought it would be a really good opportunity to get Susie as our official COVID vaccination team GP liaison to give us a bit of an update on exactly where things are at, because I don't know if anyone's like me, they've kind of lost track of where things are at and who's eligible for what and at what dose. So we thought it'd be really helpful to see where that is and maybe get a little bit of an idea of where things might be heading in the near future. So Susie's going to give us a bit of a presentation. There'll also be following up from our team a link to a survey coming in the next couple of days to try and get a bit of a picture of how general practices are feeling around SA on doing further vaccinations going forward and how we can really maintain our impact and penetrance with vaccination in the community. After Susie's spoken, I've got a few little updates on bits and pieces to run through with you. But without further ado, I think I'll hand over to Susie.
Thanks, Melanie. I'll just share my screen. Okay, is that up and running for you all? I'll take that as a yes. I can't hear you.
Perfect, Susie.
Yep,
looks good.
Lovely. So thanks for having me tonight. It's great to be able to talk to you, and I'm hoping to provide an update of lots of different topics with regards to vaccination, just to go briefly over a whole lot of different things. And there are a lot of links in these slides and resources for you. So I'm intending that it's a reference that you can come back to. We'll email it out to you with some other resources as well. So just to start off, I wanted to give you a bit of a snapshot of our progress. To date, since February last year, we've provided over 4.5 million doses of COVID-19 vaccine to people in South Australia, which is a fantastic effort. And you can see here that for the total population, about 84% have received a full primary course. I've highlighted in pink, I hope you can see it just in the primary doses 5 to 19-year-olds, that there are some areas there where we don't sort of reach a 90% coverage. And so I'm just highlighting this because with the next peak expected in November, it's a great opportunity over the next month and a half or so to be encouraging people that may not have yet considered vaccination or haven't had a second primary dose to get that extra protection. And with regard to booster doses, I've highlighted in green those groups who are eligible for either a first or a second booster but haven't taken up that opportunity. So you can see there that there, for example, are quite a number of people over 50 that ATAGI have recommended are vaccinated, but only 23% roughly have taken that up in South Australia. So good to be aware of those groups and opportunistically be asking about immunisations when you see patients. With regard to who's providing vaccines, you can see that GPs have played a really significant role in South Australia, and that proportion of 28% is sure to climb because SA Health obviously had a big role to play with the early mass vaccination clinics, but as they've wound down, GPs and pharmacies will be responsible for providing much of the ongoing vaccinations and boosters. So we still have 4 brands available in South Australia, and AstraZeneca, of course, is available for 18 and over, but not preferred for those under 60, and there's very little of it being used now. Moderna have now got 3 different formulations with the bivalent available in October, and I'll talk a little bit more about that in a moment. Novavax is available for people from 12 years and over, but those who are 12 to 17 can't use it. It's not TGA approved as a booster, but ATAGI do recommend that if no other vaccine is suitable, then they could have that as a booster. And then Pfizer, we've had those 2 formulations for the 5 to 11-year-olds and the 12 plus for some time now. And Pfizer certainly, you can see from this data, if you look at the right-hand column of total doses, Pfizer is our main vaccine being used. So 2/3, over 3 million doses have been given of the 4.5. And then AstraZeneca early on, we gave a lot, so about 850,000. Moderna, about 400,000 doses have been given, and Novavax, about 20,000. This is a resource from the Commonwealth that you may or may not have seen. There's a link down the bottom. It was updated today, but it's a really useful quick reference guide to have a look and check everything you need to know about a particular vaccine and who can have it. So this page shows you the primary course doses. And the second page has the booster doses, and I've just circled above the middle column there where they've now included the bivalent booster. So to talk a little bit more about Moderna's bivalent vaccine, it's only approved for people 18 years and over and only as a booster dose. And it's a half-half mRNA coding for the original strain spike protein and half for the Omicron variant BA1. So this is going to be available for GPs to be administering from October, and there will be some SA Health clinics administering that as well. And yes, that supply is being distributed through Adelaide PHN and communication with GPs. So if you're interested and haven't heard, get in contact with Adelaide PHN. So just looking at eligibility, this is obviously getting more and more complex and confusing. And this slide is intended to sort of break it down. If we think about primary course doses 1 and 2, if you're 6 months to less than 5 years, only some people are eligible, but of course from 5 years, everybody is eligible. When it comes to dose 3 of the primary course, this is just for the severely immunocompromised from the age of 6 months and above. And the recommendations have been updated recently just to clarify some things, but no major changes really in the criteria there. The first booster dose is available to some adolescents aged 12 to 15 and all people from the age of 16. And then the second booster dose is for some people aged 16 and above, but all people aged 30 and above may have it. So we'll look at those different age groups, break it down a little bit more, but in a nutshell, where there's limited eligibility, it's the people that are at the highest risk of a poor outcome from COVID-19 infection who are eligible. This is a resource. You don't need to read this, of course, it's tiny print, but we've put together a 4-page resource that breaks down eligibility by vaccine type, brand, and then there's a couple of pages that break it down by age. So it's just an easy reference to have a look at and check whether the person sitting in front of you is eligible, whether they meet criteria and what they could have. So we'll email that out to you. But just to look at each age group one at a time, if you're thinking about a patient who's 6 months to less than 5 years, they are eligible if they meet one of these criteria. So it includes immunodeficiency, certain transplants and therapy, cardiac disease, airway anomalies, lung disease, diabetes, and some neurological and neuromuscular conditions and certain disabilities. So they are eligible for the standard primary course of 2 or 3 doses, given 8 weeks apart. And it's just a little note there at the bottom that ATAGI recommend that there should be a 7 to 14 day interval between the COVID-19 vaccination in this group and any other vaccines they need. And they recommend that the NIP vaccines and influenza are separated and that they are prioritised over the COVID-19 vaccine. But SA Health have recommended that we actually wait 14 days, and that's because we've got a slightly more complex vaccination program, including the meningococcal vaccine, and we also recognise that the MMR vaccines can be associated with fever for sort of 7 to 10 days after the vaccine. So to help be clear about what's going on and to not increase the risk of fever in these young ones, we've recommended that a 14-day interval is carried out between the vaccination with COVID-19 and other vaccine types. And this age group are only eligible for one type of vaccine, and that's the Moderna pediatric in the blue cap. If you're 5 years old, you can have a primary course, and there's a second vaccine available, the Pfizer pediatric. It's a little bit confusing for people that from 6 months to 5 years, there's the Moderna pediatric that can be used, and then there's an overlap with Pfizer pediatric, which can be used from 5 years and then upwards. So if you go up to 6 years, you can still use Pfizer pediatric, but you change to a different Moderna from the age of 6 years. So that's one of the little hiccups there that can result in program errors. So just good to use the quick reference chart and have a look at what age group can have which. If you go on to the 12 to 15-year-old age group, they are, of course, eligible for the primary course, and Novavax can be used from this age as well. And we change over to the Pfizer purple cap. The 12 to 15-year-olds, some are also eligible for a first booster, and this is if they're severely immunocompromised or they have significant or complex health needs and medical conditions. So this booster can be given 3 months after a previous COVID vaccine or infection. And they are eligible for either Pfizer purple cap or Novavax blue cap as the booster. And as I mentioned, that's only if Pfizer isn't suitable. That would be the preferred vaccine before Novavax. If you're 16 to 17 years old, primary course could be Moderna, Novavax or Pfizer. And a first booster can be given of either Pfizer or Novavax, but again, Pfizer is the preference. The 16 to 17-year-olds could also receive a second booster, and they are eligible if they're residents of a disability care facility or if they have complex, chronic, severe medical conditions or disabilities that are going to increase their risk of severe illness after a COVID-19 infection. So the second booster, just like the first booster, is given 3 months after previous COVID-19 vaccination or an infection. And the options are the same, the Pfizer purple cap or the Novavax blue cap. 18-year-olds and over have a greater range of vaccines that can be used. I've added in the AstraZeneca, although it's not the preferred vaccine for people under 60. And a little note there too that AstraZeneca is the only vaccine that is recommended to have a longer interval between dose 1 and 2, and that's a 12-week interval. But for all of these vaccines, the primary course dose interval can be reduced if there are special circumstances down to 3 or 4 weeks, depending on what type of vaccine is being given. You can look at that quick reference chart to check, but that would be in circumstances such as somebody who's severely immunocompromised and there's concern that they really need to get both doses of their primary course being administered as soon as possible. Looking at the first booster for 18 years and over, we add in here the Moderna Bivalent. So there are 5 options, but of course you would generally only use the AstraZeneca over 60. And if you're looking at a second booster for people 18 years and over, again, there are specific criteria. So anybody 50 years and over can use it, or if there's a person in a disability or aged care facility, or people with significant healthcare needs. And the cohort between 30 and 49, this group are eligible to have the second booster. It's not strongly recommended by ATAGI, but it's certainly worth considering. And this is something that we recommend people talk with their doctor about, the risk-benefit decision. The second booster, as I've said before, is given 3 months after your COVID-19 vaccination or infection, and the different options are the same 5 as for the first booster. So that's a lot of information about eligibility. I just thought I'd touch on pregnancy as well, just to say that both the primary course and the first booster dose are strongly recommended for women who are pregnant because of the increased risks to a woman and fetus during pregnancy if they're unvaccinated and if they have a COVID-19 infection. But the second booster dose, it's not specifically recommended by ATAGI for pregnant people at this time, but it is available, and it's recommended that a discussion with the GP is worthwhile to just consider individual health needs. There are a few shared decision-making guides that are available. So this includes information to go through with your patients who are pregnant or frail elderly people if you're considering what's best in their circumstances. So I've put a few links there. There's also a really good decision aid provided by NCIS that you and your patients might find useful. Just in case you have patients coming in wanting a particular brand and you want to know where they can get it if your general practice isn't providing that. This is just a breakdown of where each brand is now available. And down the bottom is the link to the Commonwealth Vaccine Clinic Finder, which is really useful if you pick out a particular brand and a particular dose, particular age group. It's really helpful. If you have people with complex needs who might need extra support for vaccination, they may not have been able to access it for a number of reasons, such as limited mobility or needle phobia. It might be that they have autism or intellectual disability and may just have that need, or they might be remotely located and haven't been able to access vaccination yet, or all the doses that they're eligible for. So there are specialist immunisation services both at the Women's and Children's and the Royal Adelaide, and they can provide special circumstances such as low sensory environments. They can have pre-appointment consultation to help people have the opportunity to ask lots of questions and have reassurance. They can also provide extended consultations. They might even provide sedation at both of those hospital-based clinics if that's required. And the SA Intellectual Disability Health Service also provide those extra supports and can even vaccinate in the home if that's required. In-home vaccination can also be organised through Adelaide PHN, and so get onto that email or phone number if you have a patient who really needs to have the vaccine provider come out to their home. I've included a few numbers that might be helpful if you have a patient who wants to get a bit more information for themselves, or if they need to have information in another language for their hearing or speech impaired. And also the Disability Gateway number is really useful if you have clients in regional areas that might be having difficulty accessing vaccination. They're able to help advocate and find a pathway to make that happen. Just a brief note about the Australian Immunisation Register. Of course, all COVID-19 vaccines have to be logged on air, and it's best practice to check air prior to vaccinating. We have errors come in from time to time because when somebody went to log a vaccine, they found out the person had already had all their required doses and may not have been clear about what was required. So that's really worth doing first. I've listed the 10 vaccines that can be logged in air. So the 4 highlighted in blue are the ones that we have available in South Australia, but there are 5, so it includes also the Janssen CELAG that have been approved by TGA. It's just that that one hasn't been made available. And the other 5 are the ones that the TGA recognise that are given overseas and can be logged to be recognised as somebody having received a vaccine elsewhere. This is just a little note about adverse events following immunisation, and hopefully if you're a COVID-19 vaccine provider, you will have seen this poster that we've sent out to general practices with an information letter just to remind people that fever is more common after COVID-19 vaccination, especially in children aged 6 months to 11 years, with a significant proportion experiencing fever. And so just a reminder to clinicians to consider asking about immunisation history if you're seeing young ones presenting with fever. With regard to adverse events following immunisation, it's mandatory for us to report serious or unexpected adverse events that occur after immunisation, or if they result in a healthcare attendance. And so there's a link there to the form that you can use if you want to report this. Patients can also report it themselves. And if it's easier, you can phone the clinical advisory service in our team and they will take the details from you. That's just a weekday service, but if you had a really serious adverse event occur and you wanted to make sure that you got onto us straight away, you can call the number out of hours and that will be passed on. I just thought I'd put a note in here to say that the guidance on myocarditis and pericarditis after COVID-19 vaccines was updated last week. And it's really just focusing on the fact that they wanted to update information to say that all the COVID-19 vaccines can be associated with a rare risk of myocarditis and pericarditis. But the benefits of vaccination in protecting against COVID-19 still greatly outweigh the risk. So it's just useful to know that it's not just the mRNA vaccines that can be associated with this cardiac inflammation. And the risk is greater in males under 40 years of age and mostly after the second dose. But certainly we're pleased that the interval between the primary doses has been extended and recommended to be the 8 weeks because we're expecting that this will reduce that risk. Vaccine administration errors or program errors. It's really important that we collect information about the errors that are made. And so this could be that there's been an incorrect storage or the wrong site was used, dosage or interval was incorrect, and so on. And so there are just a few links there to remind you about how to go about reporting it. If it's been a cold chain breach or a use of an expired vaccine, then as well as reporting it to SA Health with that vaccine reaction report form, it's also important to report it to the Commonwealth Vaccine Operations Centre. So I've included their details as well. I've just got a few slides here to give you information about vaccine exemptions. Basically, every slide I've put here is an answer to a question I've had an email from a GP about, so I'm hoping that this will answer a lot of your questions. So there are a few different types of exemptions. Permanent medical exemptions from COVID vaccination are rare because they're only granted if somebody cannot have any available brand. And the reasons would be if they'd had anaphylaxis to previous doses or components or a really serious adverse event. So not many people would require a permanent exemption. But temporary exemptions are requested more commonly. And so if it's for the general population, they can be granted up to 4 months by a GP. And you do this by logging into PRODA and AIR, or you can click on that exemption form link. And there are a few criteria there that can make somebody eligible for a temporary exemption. Probably the most common one is a confirmed infection with COVID-19. For healthcare setting workers who are mandated to have the 3 doses of COVID-19 vaccine, there's a process I've listed there of applying for exemption through the Chief Public Health Officer. But just a note down the bottom that if the person's had their full primary course and they just want to defer their 3rd dose and have an exemption because they've had an infection with COVID-19, they don't have to go through this process. They can just provide the evidence of the positive COVID-19 test or the text they received after they logged their positive RAT test, and then they're able to defer their 3rd dose for up to 4 months from that positive test. And just finally, a note here about COVID-19 vaccination training. For all of you who are providers, you will have already completed this training, but new updates become available anytime there's a new vaccine. And so you will be able to log on soon and see the Moderna Bivalent module coming out. For any of you who are interested in getting involved in the training, it's free and online, so feel free to participate in that and become a COVID-19 vaccine provider. And finally, just a page here with some links to our clinical information page for SA Health and also our clinical advisory service where you can speak to our registered nurses who have a lot of experience in talking about the vaccine schedule and also adverse events or program errors. And you're very welcome to email me with any questions. Very happy to help out. And I'll keep an eye out in the chat if you've got any specific questions that I can answer tonight too. Thanks, Melanie.
All right, thank you, Susie. And we'll just get you to stop. Yeah, fabulous. And I do apologise. Unfortunately, our emails are merging over to a new system today, and I've had a few technical issues. So thank you for getting underway. Now that was a really, really informative presentation. Thank you so much. We've had 3 questions, and I'm hoping you may be able to answer these live because I think they're quite helpful questions, if that's okay.
Sure.
The first one was, if you've had 2 vaccines and then have COVID, isn't that like having the 3rd dose? What's sort of the rationale behind the booster dose at that point? If you're able just to explore that, Susie.
Sure. Look, I think the general understanding is that, yes, infection does provide some immunity for a time, but not to the same extent or for the same duration as having a booster. And so it certainly is preferred that even though somebody's had an infection at any point in the schedule, it is still worth considering having all the doses they're eligible for. It's going to provide a longer lasting coverage. And certainly with the bivalent becoming available, it's going to provide broader coverage potentially to a range of different variants that may be around.
Fabulous. Thank you, Susie. And also, you know, just to add to that as well, I mean, that was why that advice from ATAGI did come out around delaying after active infection, because it was seen as that essentially having a hybrid level of immunity by having that active infection. And it's been really interesting in that space. So, all right, next question was around the Moderna bivalent dose. Where are we likely to see that available across? Is it in general practice, SA health clinics? I don't know if you're happy to explore that, Susie, and then I'm happy to certainly come in from the SA.
Sure, yes. So Adelaide PHN has been in contact with over 200 general practices to invite them to participate. They haven't got final numbers on how many GPs will be participating, but it's also going to be provided by some SA health clinics, and we'll wait to some extent to see which general practices in which locations are going to be providing it, so then we can fill in some gaps. But at this stage, I'm waiting to hear about pharmacists. I haven't heard back from the chief pharmacist today yet to hear if they're providing it. But I would be expecting that at some stage that will be replacing the other Moderna that's available for boosters.
Fabulous. Thank you, Susie. So I think we're going to see more and more of a transition away from mass vaccination sites, and to flag that with all of our wonderful participants online tonight, that the intention is that SA Health does step back from these sites to enable then that reabsorption back into primary care. But also I think there's other opportunities to think about the councils as well. It's still local government is still not really involved with the COVID space so much, more so on the flu vaccine programs, but there's an opportunity to think about that as well. So just for awareness, the intention is not that SA Health will continue to provide vaccines and mass vaccine sites, but regionally we know that's very important for some locations to maintain and elevate the local health network presence. Thanks, Susie. And final question that we have is around if a patient has had myocarditis or pericarditis and it's seen as an idiosyncratic event, therefore, can they have another booster dose, or is it an absolute contraindication? What would be your advice? And I'm sure you get a number of these queries coming to you, Susie.
Yes, yeah. No, it's definitely not an absolute contraindication. And so it's the update that came out just in the last week from ATAGI, the guidance on myocarditis and pericarditis looks specifically at that question. So it's worth reading that latest update. And if in doubt, consulting with the person's cardiologist or the specialist immunisation clinic at the Royal Adelaide. You can refer using the form that's in my PowerPoint link. You can then also the person can have a phone consultation if they're in the regional area, for example. They don't have to travel to the Royal Adelaide to get that advice, and so they would be able to get specific advice looking at their condition and their wider medical history as well.
Fabulous. And just another question, and then we'll move to the next update, was around, is a 5th dose or a 3rd booster for the general population in the pipeline?
It's not something that I've heard being discussed as far as a plan with ATAGI at this stage, but I think that everyone expects that at some point down the track we'll be looking at having further boosters in a similar way to what has happened with flu, that if we're going to continue to see peaks and as immunity wanes from previous boosters, that we'll need to consider how we can protect the population. But it's interesting, if you look at World Health Organization websites and other information, that there is still a lot of research going on into new vaccine candidates with over 200 sort of in the pipeline. And so we're going to be having continuing improvement in the technology available to protect ourselves from COVID-19, which is great.
Wonderful, thank you, Susie. Now we have one further question. When people have had COVID and not very well, they often don't feel inclined to have a further immunisation. What is the benefit of them having a booster?
Yeah, I think it just comes back to, again, the fact that the only way to have continued protection is to boost that immunity. And so an infection, while somebody may have been very unwell, hopefully counselling them that by having a booster down the track after they're eligible, 3 months later, or when they become eligible for another booster in the future, that is the best way to prevent themselves from having severe disease again from COVID-19.
Wonderful, thank you very much. And of interest, I thought it was quite interesting, the definition, and we will have a series of long COVID presentations coming up in October, which we think will be really useful for the GP cohort. I know Mel's going to touch on that, but particularly the definition change now to include post-vaccination in that long COVID definition as well. So it is really interesting. I thought just thought I'd share for the group. Interestingly, we, as some of you may be aware, there's been a recent tour that's occurred between the Australian and Israeli two different medical research groups, enabled some staff, and particularly some of our key public health leads, including Professor Spurrier, to travel to Israel at the beginning of this month to look at their COVID response. And so far, we've had some really interesting feedback, particularly from the New South Wales Chief Health Officer, that we are certainly seeing a really interesting response in Israel in terms of how that vaccine program has rolled out. And there's certainly no intention to move further in terms of their vaccines at this point in time for otherwise well individuals, but of course immunosuppressed individuals are still in that 5-dose regime at the moment. So that would be of interest. We were expecting the Pfizer, the Bivalent, or the new Omicron specific Pfizer vaccine will be available at the beginning of next year as well. So that may also influence the program. And thank you for clarifying that question as well on the chat, just around if they were not very unwell with COVID, should they then seek further vaccination? And I think I presume your same advice, Susie, would apply in terms of that vaccine, but also noting as well that did that interval as well, the 3-month interval.
Yes, I've certainly had people say to me, I've had COVID, I didn't get sick. So feeling like that would mean that is their future prediction that they will never get too sick with COVID infection. And I just don't think we can be confident that the way you have responded to one infection will be the way you always will. So, I'd certainly want to have that protection because we know that the rates of severe disease drop significantly when you're vaccinated.
Yeah. Wonderful. Thank you so much, Susie. I might just quickly whip through some slides that I was going to share and then I'll come to you, Mel. Is that okay, Mel? Yeah, fabulous. Thank you so much, Susie. Really informative. And of course, please continue to post any questions you have in the Q&A, and I'm sure Susie will be very happy to answer them answer them by written format as well. Okay, so I'm just going to share my screen. Hopefully you can all see. Yep. I think that's come up on everyone's screen. Yeah, fabulous. Okay, so just in terms of, I'll just check sure just because I'm having a few technical issues, just checking that moved slides. Did that move, Mel? Yeah, fabulous.
Yes, it did.
But wonderful. I couldn't unfortunately get out some of my slides out of my emails because of the it's all shut down now for 12 hours email access. So apologies. You're going to have some. So I'm going to talk through some of this content as well. First of all, I just wanted to highlight where we're now seeing this trend now around the epidemiological data with COVID, and particularly we're at this real baseline period, which is fabulous to see. Really, this is the lowest point since we've been back in early December around where our current cases are. We're sitting at 43 admissions in the hospital system today, so pleasing to see. But of interest and note, we're of course now seeing people who are fully vaccinated being admitted into our acute system. And when we go back through and look at why individuals are being admitted, we do need to look particularly at the over 70 age group, early access to antivirals being critical in this space, and also individuals with advanced renal disease. We're still seeing quite a number of presentations in that space as well. So just to keep that on your radar as well, the important role of antiviral early access, and of course testing them in that early space. Just in terms of the other states and where we're sitting, all states are sitting in this same period. So we're now going into this baseline period, which is fabulous to see. If we look at the hospitalisation data, and this is per 100,000 population group, just interesting to see where SA is sitting right in that middle space New South Wales is still having quite significant hospitalisation data currently, and it is of interest that's also being reflected across into the ACT as well. It's of note that they are now going back through and just really reconciling some of their data and their hospital in the home admissions, which also forms some of this as well. So just for awareness, we're not too concerned given that we are tracking around that Victorian number, which is a really good benchmark for the state in terms of that 100,000 admission rate, noting they run a very similar admission profile criteria to what we do here at SA. And then again, you can see where we're sitting in terms of that national data and SA data sitting well below where nationally we're sitting as of Friday. Now, some of you may have seen this was the COVID modelling data that was released on the 18th of August. And what it does demonstrate is really we're tracking exactly where we expect to be at this point in time. And this is around cases, around symptom onset cases. And you can see we expect around the 25th of October that we'll see those cases increase. This is consistent. This was state-based modelling that was undertaken through SAMRI, the University of Adelaide, Professor Josh Ross. What we do know is that this is similar modelling has been undertaken nationally through the Commonwealth. Other states have also undertaken modelling, and it's all indicating a November wave across the states. Now, that's based on waning levels of immunity from vaccination, and also the fact that we do know, given the active cases that we had in July, where we were sitting at that really high case count around the 19th, 20th of July, that we expect based on immunity from active infection, that hybrid position would then lead to that increase in cases at that point in time. And that's not taking into account any new variants that may be emerging as well. And of course, modelling will take that into account. We have just had the modelling also undertaken as well based on the changes around isolation, and that's taking into account a 5-day isolation period, noting this was when we were at 7 days, this modelling, but a 5-day isolation period, and also now looking to see what does it look like removing isolation as well. Noting there's always a really interesting point, I've said this before in these webinars, the fact that when we look at the isolation, in fact makes reasonably minimal difference around the isolation period in comparison to the close contact requirements for quarantine. We're noting quarantine in close contacts is much more effective than what it is around individuals who are COVID positive in isolation. And that's because of the fact that we know symptoms may be around for a couple of days before someone's testing, then isolating when they're that most infectious period, whereas close contacts would then be in that quarantine when they were in that really infectious time. So that's just something to keep in mind, and I'll just come to why that's important in a minute on this slide here. So this has just been released now, and some of you may or may not be aware that this was undertaken, which was the CSIRO undertook a really big review around pandemic preparedness for the nation, and a significant number of submissions provided. Each of the state departments put submissions in. Expert advisory groups also asked for position on what does it mean now for Australia's pandemic position moving forward. And just interesting, I think, so just a 3-page executive summary that you can just have a look online. Interesting to see around what this will mean if there are new variants, and the role of quarantine, short stop measures to be able to quickly put quarantine in place if there is an uncertainty. And I think that's just quite interesting to have a look through. So I encourage you to check out the new CSIRO report, which I think was released a week or two ago. Now, the next 2 years is where we're sort of now focusing on our COVID efforts, noting the fact that really the way we've been responding to COVID, big systems, big responses from SA Health, big responses then are expected in the community space as well to be able to keep up with patients. We expect to see that really integrated back into how we would manage influenza type illness. So how do we manage it now in that pre-2020 state, but of course with different supports, different funding options, and different ways. And of course we now use virtual and telehealth support. So what we are now pulling together is a sort of a 2-year plan of where we see things sitting from the SA Health facility, but more broader across the system, looking at governance, data, communication being a really key point, digital initiatives and workforce as enablers coming together to support an integration piece. So being really clear that we've got to work better together between the acute system and primary care for the sake of our patients. We need to make sure the system's easy to navigate, because at times it is very, very confusing. And the National Coronavirus Helpline has been helpful because it's acted as a navigation piece. And then we've had our virtual GP assessment team support. The importance of preventative and public health and self-initiation of measures such as masks. So when we go into that period in November, encouraging people at that point in time to be increasing their mask usage. Then we come to the health system equity, and that's across the regions, noting the fact that we have seen, reasonably almost second waves and occurring in the region. So we see the cases in metro and then seeing that response in the regional areas. So how can we make sure that we're continuing supports in place, not in very limited health infrastructure, and of course in many places not having adequate primary care in some of our regional communities. And finally, how do we make sure that our workforce, government agencies, all of us can sort of maintain this resilience, noting that we're looking at this as a 2-year next steps and next trends ahead. Now, let me go to my next slide. So yeah, really happy to have any questions posted around this, but there is a real need for us to think now around what are our next steps, and particularly I'm really fortunate the GP respiratory clinic model has been extended now to the end of the year and the funding in place for that service. However, what happens on the 1st of January? How do we make sure that patients in the community can get access, if they do have respiratory symptoms, with a GP in a safe, supported way? How can we make sure that there's testing available and a referred testing option as well? So pleasing that we've had the GPRC model extended, but we need to be thinking at this point in time, how do we start a slow integration so it's not a sudden shift off on the 1st of January, where the expectation will be that people will be ringing up asking for request forms for testing, for instance, or requesting to come, I need to be assessed, how would they be seen? So there's a bit of work happening behind the scenes, but we're really keen to see what support initiatives may be put forward through the Commonwealth upcoming budget. And noting we've seen really increasing support from, for instance, from the Victorian State Government to be able to support infrastructure payments for general practice to pick up and support some of this respiratory support in the community. I just want to quickly touch on 4 things, and then I'll hand over to Mel. The first was around the QR codes, and for awareness, that was system was decommissioned last week. So no more QR codes are required in healthcare facilities, and that was particularly for aged care facilities and for private public hospitals. But I've been around to a couple of, and thank you to those of you who welcomed me into your GP clinics, I've been around to a couple of GP clinics, and interesting, we did know that there was a few places still using QR code check-in. There's absolutely no point doing it because we're not now accessing that data. So please remove any signs if you have them, and of course, if you do decide to keep a register of patients, for instance, that come into or you're worried about visitors coming in, you can certainly do that, but it won't be held under the same privacy provisions under the Emergency Management Act. The flu vaccine, I just want to bring up about the flu vaccine, if that's okay. We've seen a very, very successful flu vaccine program this year, and certainly there's a lot of advocacy happening for an ongoing integration of the flu vaccine into the National Immunization program. So watch this space around that, but certainly been a lot of value of joining the two up together. The next thing I want to mention was around N95 usage, and 2 avenues to this. The first being that the local health networks in the hospital have now taken a stepped back approach, particularly around surgical mask usage. So we know that surgical masks are now becoming mainstream unless someone is caring specifically of the COVID care of the COVID positive patients. So seeing that change now in emergency departments, but also on the wards as well, back to surgical masks in that proportionate response, but also as well, the PHN and the Commonwealth did announce last week, nearly 2 weeks ago now, an ongoing support for PPE for general practice. So again, knowing, and I know Crystal will link us in with this, but making sure you know that the PHN can continue to support if you're unable to access through N95s as well. And finally, the virtual care service I wanted to flag, and for many of you may not be aware of what the virtual care service is, but it's an SA Health initiative to set up a way to better coordinate and navigate care for patients in the community. And the virtual care service currently sits at Tonsley. And it has been was rapidly set up in November, December last year to then for the borders opening, particularly as an clear ED avoidance strategy. But what I want to flag with the virtual care service, and we'll probably need to do some really clear specific comms out in our GP update, is that they are now, from this week, now offering a service out to all residential aged care facilities in the state, that if patients need urgent care or support and the site is considering calling an ambulance, uncertain what to do, there is emergency basin support available. And we are looking at how we can integrate a GP model into that service as well, leveraging and thinking about all the good things we've done with COVID, with the amazing group of GPs that we have within SA Health, how can we now think about the virtual care space and having a GP coordination navigation piece? I think that's particularly important for the aged care, residential aged care facilities, where we know often it's around inability or difficulty accessing GP care or GP support, particularly after hours. So we'll put a bit more information about that, but just to flag, there is a virtual care service in the state. It is expanding, and we're seeing further work now happening in the residential aged care facilities, just in case you may have heard about it or want to know more, and very happy for you to send us an email as well. That's probably it from me now. So I'm going to stop sharing my screen, and thank you so much. I'm going to hand over to Mel Smith.
Thanks, Emily. Let me see if I can make this happen. Oh. Try and get this slide show happening. There. Hopefully I can get a thumbs up. Brilliant. Thank you, everyone. So really,
you're not sharing your big screen though, Mel. You're just sharing your slides on the side as well, though.
Oh, that's immensely frustrating. We will fix that. There we go. I have the world's slowest computer, everyone.
But also not helping that all of our computers are being updated tonight either, which we didn't realise when we organised this webinar.
We did not time it well. Okay, let's try this one more time. Hopefully that one's working a little bit better for you. Oh, we've scrolled down a few
Fabulous.
slides. There we are.
Slides really well.
Perfect. Back to the beginning. All right. So really tonight, I just wanted to update everyone on a few different things that have changed over the last couple of months. We've kind of gone through this amazing period where SA GPs particularly have really stepped up and done an amazing job around prescribing oral antivirals, and we have some of the highest prescribing rates on the PBS across the country, which I think is really impressive. So there's been this huge effort in primary care, and we've kind of all managed to get through the worst of that, I think. And as we see the case numbers come down now, and as Emily has alluded to, some of the resourcing around this COVID response is sort of shifting a little bit, and we're trying to move back to something of a, if you can call it, business as usual type model. So there's been a few changes recently around some of the resources we've been using in primary care to look after our patients in the community, and I just wanted to make sure that everyone was up to date with what was going on. And some interesting stuff in particular. First up was what came out of the survey that many of you did a few weeks ago. We had, I think, it's about 340 GPs responded to our survey around sort of respiratory pathways and how we're going to look after COVID patients in the community going forward. And of particular interest was this question around prescribing antivirals and the use of the new NBS telehealth item number, the 93716, that came in sort of late July after some significant advocacy from various groups to bring back a greater than 20-minute telephone consult item number, particularly just for antiviral prescribing. We were quite surprised in the response to the survey that of people who had done some oral antiviral prescribing, there were probably 35% of respondents hadn't actually used that item number. And we weren't sure whether that was because of the timing of when that was introduced, or whether people still weren't necessarily aware that they could use it. So as you can see, it's quite a significant proportion in that middle section who haven't actually utilised that item. And I think it's important to know that it's there and that you can use it and help to maintain the viability of your practice. So I just wanted to run over a few basic facts around this item number. It's basically allows for a telephone consult, gives you for VR GPs, it's equivalent to a level C kind of consult, and is only, it's been confirmed it will be available at least until 31st of December this year. And can only be used when you're consulting with a patient who has a confirmed positive COVID-19 result. RAT or PCR, doesn't matter as long as it's confirmed. And the purpose of the consultation is really to assess the patient's eligibility for oral antiviral medications, and including provision of the script if clinically appropriate. And of interesting to note that this won't be included in the kind of pattern of services thresholds for automatic referral to the PSR. So a lot of talk around that's the 30-20 rule going forward for telephone consults, and this would not be included in that because it's needed for a very specific purpose. So as you can see, the benefit is same as a level C face-to-face consult. There is no requirement to bulk bill the consult, so feel free to charge a gap as appropriate for your patient base. And basically it's for any consult over the phone requiring more than 20 minutes. For the non-VR items, it's more than 25 minutes. And it just requires you to take a history and assess your patient's suitability for prescription of COVID oral antiviral medication. And they have to have obviously confirmed COVID-19. And it's also does not require the patient to have fulfilled the 12-month rule around having to have had a face-to-face service at your practice in the 12 months preceding, because obviously they have that exemption being COVID positive. They will be able to have a telephone consult without having had that previous attendance. Important to know that the treating practitioner, in the notes for this item number, the treating practitioner must confirm a patient's positive COVID-19 diagnosis and has to confirm that they've actually reported it as per whatever their state or territory reporting requirements are. So if someone tells you, oh, I've done a RAT test, but I haven't reported it yet to SA Health, you do need to encourage them to do that or assist them to do that. And make sure that you record in your notes that, you know, they do have a positive result and that they've said, yes, I've reported it. Okay, so that was all I wanted to say about the MBS item number. Go forth and bill as appropriate. The next thing I wanted to talk about was some recent changes as came out in the GP update yesterday around our COVID care centres in Metro Adelaide. Important to know that the Northern Adelaide Local Health Network COVID Care Centre, which has primarily been around to facilitate antiviral prescribing through the National Medical Stockpile, has now ceased operations. The Southern Adelaide Local Health Network CCC at Flinders will be finishing up on September 30, which is this Friday. And the Carlin Central Adelaide or Royal Adelaide Hospital COVID Care Centre has now actually relocated to the Sefton Park Hospital Avoidance Service location. So they are continuing to operate. The Carlin CCC continues to see COVID positive patients face-to-face to help sort of avoid the need for them to present to ED. It is still via referral only, using the same methods that have been used previously, and they are continuing to provide first dose of intravenous remdesivir infusions at that site. There is still, for access to oral antiviral medications through National Medical Stockpile, as opposed to PBS, we still have our ongoing central referral system to access that. So just important to note, and as per our update that came out yesterday with contact details for the Carlin CCC, just understand that if you refer a patient in and they're going to need IV infusions, if they're in Metro Adelaide, the first dose is likely to be occurring at Sefton Park, no matter where they are in Metro Adelaide. Second and third doses will generally be given using My Home Hospital. Previously, those first doses were happening at Lyle Mac or at Flinders. We just haven't seen the demand over the past few weeks, and we don't expect that demand to continue at a high enough level to justify continuation of those services. And in terms of alternative ways you can facilitate face-to-face review for your COVID positive patients if you have concerns about their symptoms of COVID or other medical issues. Obviously, as Emily has already alluded to, we have had extension of the Commonwealth funding for the GP-led respiratory clinics through to December 31, and we have continuation of their extended hours for the moment. So please take advantage of those facilities to provide those face-to-face reviews. There's really been a huge step up in their ability to look after our COVID positive patients and provide that hands-on assessment as needed. In the regions, the arrangements have not changed significantly. There's always been that sort of cooperation between local general practice and the hospital facilities in regional LHNs. So there hasn't been a dramatic shift there, and that's continuing as is. And the Carlin CCC, as I mentioned earlier, are now accepting referrals from all across the Adelaide metro area for face-to-face assessments of COVID positive patients. They're operating 8:30 a.m. to 8:30 p.m. 7 days a week. There's 2 different phone numbers you can use to get through to the duty doctor and email to sort of send through supporting documentation. So don't forget to take advantage of that. So how does this affect access for your patients to receive COVID antiviral medication through the National Medical Stockpile? We still have our centralised referral process via our new online portal, and hopefully a few of you have tried that out already. Access to actually getting the medications in regional areas remains unchanged, but in Metro Adelaide, whereas previously you would select your hospital site, you generally would choose Lyle Mac, Royal Adelaide or Flinders as a site where you would send your patient to pick up their medication and have their assessment and talk to the team there. It's now going to go through some different pathways in the back end. As I mentioned earlier, remdesivir infusions will likely happen their first dose at Sefton, and then second and third doses will happen in the home, which is much more convenient for patients. Oral antivirals, we're still in the process of determining how best we can actually physically get those medications into the hands of patients, because obviously if people are a long way from Sefton Park, we don't want them necessarily having to physically get there to pick up a packet of Paxlovid or Lagevrio. So we're just working through those processes at the moment. Continue to refer through the centralised pathway to their nearest LHN location, and we're doing our best in the background to facilitate that efficiently for patients. As long as you refer through the system, whoever picks up that referral within the LHN system to provide those medication will arrange directly with the patient how best to get it to them. And just wanted to sort of go back to that, give you a bit of a screenshot of the treatment and referrals for COVID-19 webpage, which has a whole bunch of really useful information on there around all sorts of bits and pieces, and has the link through to the online referral form through the portal. So I just wanted to sort of make sure you're all aware of that website. If you type in SA Health, COVID mild illness treatments, COVID-19, you'll get this site in Google. So the most important piece for accessing antiviral medications is this, this part of the webpage down at the Refer Your Patient link, which has the link to our COVID-19 outpatient treatment referral portal. So that actually takes you through to an online form where you can upload a specific PDF referral form. So I wanted to kind of show you what that new portal looks like. You may recall, many of you who used this earlier in the year, we had a quite exhaustive online form. You had to type in all the information for your patient. That went through about 15 pages, I think, that form. Took a lot of detailed information, which was immensely frustrating when you have all that information in your practice software. What we've tried to do is come up with an option that will allow you to download a PDF form into which you can type the information. We also shortly will have available a template that you can incorporate into the major GP practice software. We've got a best practice template, a ZMed template, and a medical director template that we're hoping to actually get up on this website for you to download and incorporate into your software, so that you don't have to do a whole lot of typing. It will automatically pull in medication information, past history, patient contact details, and hopefully make this a much quicker process. This is a picture of the PDF form that's available that you can use. So you can actually save that to your hard drive and complete that and then upload as needed. The important part on the referral portal is really to note that you can upload the specific referral form, but you can also upload extra forms. So if you can't be bothered typing everything into the referral form, you don't want to type out a long medication list, you can upload the referral form that says, see attached patient health summary, and you can actually generate that from your practice software if need be and upload 2 forms, and that will all go together as a package to the LHN to then process that referral to help the patient access the medication they need. So hopefully this will make it a little bit easier longer term. Okay, so that was kind of my updates on the NMS access for COVID antivirals. The next thing I wanted to touch on was Evusheld and the pre-exposure prophylaxis medication that I know we've heard a little bit about in the past, but there hasn't been a lot of information around how we can get our eligible patients to access this medication. Evusheld is a combination of monoclonal antibodies that's really designed to be given to patients who are extremely high risk of severe COVID infection. So people with really significant immunocompromise, so people who've had organ transplants or have significant hematological malignancies, that kind of thing. We have quite clear eligibility criteria set at different tiers, and that's available on the website. So that same website where you can refer people through for antivirals via NMS. There's also a bunch of information around Evusheld and the eligibility criteria to access that. So there's a document that outlines specifically who fits what tier. Currently, the limited supply of Evusheld is being given to tier 1 and tier 2 patients. And up until now, that's primarily been accessed through the non-GP treating specialists who generally look after these patients, because they all have such significant illnesses. It's very rare to have any patient who's eligible for this medication not to already be quite tightly integrated with the non-GP specialty services through the hospital system. So often, it's their hematologists or their neurologists or oncologists or transplant physicians who are kind of looking after them and are helping them to access this medication, which is given as 2 IM injections. So it's pretty simple to administer. So it's been available so far through public hospitals, some private hospitals, and a new recent innovation has actually been to set up a process for access through some of the priority care centres in Metro Adelaide. So there has the SA Pharmacy and the Office of Chief Pharmacist have now set up an online portal for referring patients, eligible patients in for Evusheld treatment through a very similar online portal to the one we use for accessing antiviral medication. So there is a specific form that needs to be completed, which really outlines clearly how a patient meets criteria and fits the eligibility under their risk profile. And that portal can be used to actually refer the patient into for a dose of Evusheld through the priority care centres. It's really important, though, that this is a single dose medication currently. It's expected to provide protection for probably around 6 months, but it is not clear at this stage. There is no plan for second dosing currently of the medication. So it's really important that if you do refer a patient through, that you make sure they haven't already had a dose in the past via perhaps their non-GP specialist who's looking after them. And if you do organise for them to get it, that it's well communicated through to all the teams looking after these patients, so we don't end up with people being given this medication by their nephrologist and their GP and their neurologist or something similar. And just a little screenshot of the website that has all the information around Evusheld and how to access it. Again, we have a link to the treatment referral portal, which works in a very similar way to the antiviral referral portal. And there is also a very an eligibility declaration form, another PDF form that you can download from the site. So that was really all I wanted to kind of update everyone on. It's a few random bits and pieces. Happy to answer any questions. If anyone's ever confused about how best to navigate some of this stuff, or has any feedback on how it's working, we're always happy to receive emails to our GP liaison email address. If there's sort of immediate issues you have around navigating the system for your patients, you can always call the clinician advice line, the COVID clinician advice line, that 1800 313 090 number, and you can talk to our community COVID hub nursing staff or to our wonderful GPs who are working in the hub looking after patients. So thank you.
Wonderful. Thanks so much, Mel. So it's a really informative update around where we're seeing different areas progress. I think you've had a couple of questions, Mel, come through, which I know you've sort of covered as you've been going through, but I think it might be just helpful if we just do touch on just a little bit again around the NMS stock, and particularly why we had NMS stock and now where that gap still is, if that's okay for Mark's
Yeah,
question.
sure. So when the oral antivirals, and indeed we initially had monoclonal antibody infusions, Strovimab infusions that we used as early interventions for COVID back in the dark ages of late 2021, early 2022. These were all only available through the National Medical Stockpile, through the hospital system. Obviously, we now have Paxlovid and Lagevrio available on the PBS. NMS is generally used if we have a patient who is perhaps not able to access Paxlovid on the PBS, or because of there's a clinical contraindication, then they can be considered, if they're high risk, they can be considered for a remdesivir IV infusion, because the thought is that this is likely to be more effective than oral Lagevrio as a treatment. So we have a whole set of eligibility criteria for NMS medications in this state, which is not quite exactly the same as the PBS eligibility criteria. And it is often useful, we kind of think of it as in our preferred step down of medications for COVID are number one, Paxlovid is probably the most effective and easiest to get into people, but as we all know, that's a whole bunch of fun to prescribe and a whole lot of contraindications and interactions with usual medications. So where that is not possible, it may be worth considering remdesivir as that is far more effective, we think, on current data than Lagevrio, which is the other oral one available on the PBS. So you may be accessing NMS for orals simply because someone actually fits the NMS criteria for an oral antiviral and doesn't fit the PBS criteria. Not too many of those these days. Or there may be someone who just isn't eligible for PBS. You know, they might be from overseas and they just can't get a PBS medication because they don't have a Medicare card. Or it's really to access IV remdesivir in those specific sort of clinical cases where they can't have Paxlovid. So hopefully that's crystal clear.
Yeah, challenging, isn't it, in this space, particularly as we probably expect there'll be other therapies as well that will come online, which will then be also potentially through NMS stocks. And we do still have as well the suppliers through art shows as well, less so now the aged care facilities, but that was also challenging as well at the beginning. Okay, I think that's covered all of our questions that we've had come through. Are there any take-home messages from our panelists tonight? Susie, I'll come to you first. Anything at all you think important take-home message, and then I'll come to you, Mel.
I just think making the most of opportunities to raise discussions about immunisations again. You know, we've had a big push, but with the peak, you know, other peaks expected, asking the question again and checking whether people's feelings have changed. If they have been hesitant, there may be a reason that circumstances have changed and they might reconsider.
Now coming to you, any take-home?
I think really congratulations and great job to South Australian GPs on oral COVID antiviral prescribing. Keep up the good work. Hopefully everyone's becoming more comfortable with it. And don't forget, you can always phone a friend. Clinician Advice Line, Dartis, 2 really great resources to help you, both with this antiviral prescribing, but also navigation of the system, both for prescribing and for accessing help for your patients. So tattoo that number to your head, 1800 313 090.
Always keep getting it. Thank you, Mel. Any other final questions come through? I don't think so. So a very big thank you to everyone who has joined us this evening, and apologies around the delay in the start. I'm just going to hand back to Crystal from Adelaide PHN.
Thank you, Emily. Thank you to Dr Emily Kirkpatrick, Dr Melanie Smith and Dr Susie Pendler for their presentations this evening. Stay tuned for our series of long COVID webinars coming up in October. And just a reminder that your APHN practice facilitator can support any questions that you may have and help you with accessing PPE and COVID resources. And also Health Pathways is a great resource for general practitioners. If you need access to Health Pathways or how to navigate to the Health Pathways page, please contact your practice facilitator. Thanks everyone and have a great evening.
Wonderful. Thank you so much, Crystal. And a big thank you, Susie, Mel, for joining us tonight, and to our fabulous GPs as well for joining our presentations. Please, as always, post questions, send us questions. If you did feel there's areas we should cover in upcoming webinars, let us know. Thank you so much, everyone. I hope you have a nice evening.